Most of my medical training was done at Duke University. I went to medical school there. I did my residency training there in orthopedic surgery. And then I did my specialty training fellowship in hip and knee replacement at the Center for Hip and Knee Surgery in Indiana. Well, I was drawn to orthopedics very early on because I just liked the problems that it involved, which is quality of life for patients, patient mobility. I liked the biomechanics of orthopedics. I liked the solutions to it, the surgical solutions to it, as well as the non-operative solutions. And I just felt that was an opportunity to help patients in a very real and very satisfying way. They come into the office, they have a hip or a knee that's hurting, and I can make it better. And that's a very satisfying thing. My goal is to treat patients with respect and to try to get them up and moving and help them with their problem as efficiently as possible. We know that the nice thing about orthopedics is it's a quality of life specialty as well as a trauma specialty. And in either case, the problem is patients can't move the way that they used to be able to. And my job is to get them that perfect hip or perfect knee or fix that hip fracture as well as I possibly can, because we know now that makes patients healthier. That mobility is good for their heart, their lungs, their mind. It makes them happier, and now we know that it makes them live longer. So I see my role as being a very vital one for my community and society in general, but really for those individual patients as well. It's about being able to live without chronic pain and being able to get up out of bed and do the things they want to do. When it comes to hip and knee replacement, the issues today really are technical and surgical, and that is, how can we get these implants to last forever, and how can we put them in patients so that they can get up moving as quickly as possible with minimal discomfort. So from my end, for example, with hip replacement, I've gone to doing a direct anterior hip replacement, which simply means that the approach I use does not involve having to detach any muscles. It's all done between muscles. And what that has meant for patients is when they get up the very next day and walk around, they're not having the soreness and the pain that they were before, and they have no restrictions as far as their positioning as they have with traditional hip replacement. And knee replacement as well involves not only doing the procedure technically correct, but trying to do it in a way that we have to move soft tissues around minimally so the patients are more comfortable. And of course, trying to anticipate any potential issues or problems before the surgery so that patients don't have any difficulties afterwards. And that just means that they can get up and out of the hospital more quickly and get back home and be more productive right away. I think if my patients saw me outside of the clinic in more of my home setting, they would see me spending a lot of time with my daughter and see me doing just about anything I could to be outside. I spend all day either in the clinic or in the OR, so when I'm home, I want to be in the garden or be in the garage working on a project or be out with my daughter playing. That's really what it comes down to.